We'll be live on time. Good morning, everybody. It is June, oh wow, 21st. I just put two and two together. 2024. It's about 11 a.m. on the East Coast, and we are live with Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. I am Lisa Salberg. I am your host, and today I am joined by Dr. Harry Lever. Good morning, Dr. Lever.
Morning.
So I just looked at the date and it didn't hit me until just now. I got to do some math here. It is, my goodness, the 71st anniversary, wow, of my grandfather's passing. He died on this day, 1953. I think I did the math right there. He was 42 years old and he had a cardiac arrest at his home on the eve of my father's high school graduation. So, remembering my grandfather today, whom I unfortunately never had the chance to meet because he was taken by HCM before we even really knew what HCM was. So, dates dates in June are rough for me. Sorry, Harry. I went down a rabbit hole there. So, welcome to Tales from the Heart. All things HCM all the time. And today we're going to be talking about the theme of the month, which is exercise. And there's been some updates to the guidelines on exercise and sports activity. So we figured we would take a dive into exercise with kind of an eye towards it's summer, we're in a heat wave, and how do we balance the need for movement and exercise within the HCM community when dealing with extreme heat and like circumstances. So, Dr. Lever, what do we think about exercise in general in HCM?
Well, I think people can exercise, but I'm a little more conservative than the guidelines that have come out. I think that you still have to be very careful. And I think if you're going to, I think walking is fine, playing golf is fine, bowling is fine, even riding a bike is okay. But I think there you got to be very careful of where, if you're doing it on an exercise bike in the house or you're outside in the heat, you got to watch that. Probably now it's safer to ride an exercise bike in the house than to go out and ride your bike, just because of the heat and dehydration and all that kind of stuff. But in terms of playing football, being a weightlifter, that kind of stuff, that I think is concerning.
So let's dial that back a little bit. We quote have to be careful. So let's figure out how people can be careful. So knowing one's anatomy and arrhythmia risks are important, correct?
Absolutely.
So a patient with HCM before undertaking any type of exercise regimen should consult with an expert physician in HCM to understand
Right.
their anatomy, physiology, and the risks of arrhythmia. Would that be a
Yeah,
safe?
yeah. That's right. That's what you have to do. I didn't get that out. Yeah, that's enough. But that was. Uh, I think that you got to know what the echo looks like. You got to know how thick the heart is, and got to check. You got to know if you're having any arrhythmia, and that's easier to do today than it used to be. We're no longer just dependent on a Holter monitor for 48 hours. Now we can monitor the rhythm for longer periods of time with different devices, and so I think that all that helps.
So understanding risk of sudden death before taking on an exercise regimen, critically important. If you have high risks, we put in a device. And then we can discuss what exercise is safe or unsafe with a consultation with an HCM expert and shared decision making. Would that be the way you would see the world today?
Yeah, I you know, this business of shared decision making. I think that the doctor shouldn't be afraid to say what he thinks. I mean, there's all when this there's this tendency now that the doctor can give you the facts, but then you have to decide what you're going to do. And I think that I have a little trouble with that. I've come from the school of, I was trained in medicine, and I need to let people know what I think.
Well, I think with proper shared decision making, and we actually had this as a topic in our last year's meeting. What does shared decision making mean to a physician? What does it mean to a patient? Obviously, people have free will and they're going to do what they're going to do. And if they do something that is potentially harmful to them, they have a responsibility there. So, part of shared decision making is understanding what shared means, right?
Yeah.
So, you have knowledge, training, experience. You are a physician, and you are going to say, here's what my view of the world is. Here's my understanding of your heart. Here's where I think your risks are. And here's what I think is safe for you to do. That's your part of the share. And the other the patient may say, well, this is really important to me to be able to go jogging every day. And how do I do that safely? So coming up with a way to figure out how to do that safely is really where the magic kind of happens. When you get a patient who's educated and a physician who's educated, then I think we can make a good decision together. But if the patient thinks, well, I don't want to, is a good enough reason to ignore the guidance of a physician, or I want to do this, not that, well, they might be sharing in the decision, but they're probably not going to make a great one.
Well,
So I agree, patients should listen to the input from their physicians, but should also share what their wishes are and come to some type of an understanding of what they're going to do.
well,
How do we help patients stay safe while being active? So let's talk about hydration.
yeah.
How,
That's extremely important, and uh, uh, particularly now with what's going on in the past week or so, you've got to really drink. And I think that one of the other things that we've got to consider is you don't want to be out at 3 o'clock in the afternoon exercising. Maybe you ought to start out at 7 in the morning when it's not quite so hot. I mean, this weather right now is, I mean, it's there's been a major change, and there are a lot of people getting into trouble, even if they don't have hypertrophic cardiomyopathy. So you've got to really make sure you don't get dehydrated. Particularly Hokum, you can really get into trouble if you have a tendency for outflow tract obstruction at rest or with provocation, and if you've got to really drink, and I think that one of the things that, and I don't want to sound crude, but you got to make sure that you're urinating.
mm-hmm.
That's a sign of knowing that you're probably adequately hydrated. And you can't, you've got to, you really have to be aware. And if one of the things that you have to watch is if the urine is highly concentrated, means the color is very dark, that's a bad sign, and you've got to really drink. So I can't emphasize that enough in the light of what's going on now out this, and we're going to be living with this, I think, for a while. This climate change business is a real problem, and we people have not taken that as seriously as they need to.
So while the topic is exercise, we know hydration is critically important. And I'm in New Jersey here. You're in Ohio. We're expected a high of about 100 today. It's June. That's typically what we get for the hottest days of August, maybe end of July. So we have the likelihood of several weeks of extreme temperatures in front of us. So thinking hydration for ourselves and for our children with HCM. Okay, let's talk about the kids. You need to make sure that they have a lot of water with them. So something happened here yesterday in New Jersey where a school bus was disabled on the side of the road for an extended period of time, and the kids had no water. Pack water bottles for your kids. Like, you don't know when they're going to get access to hydration, and you want to make sure that they have that. Can you talk a little bit about some of these electrolyte drinks and electrolyte supplements?
I think that's equally important, and I think it's like quarter. I don't know, I wouldn't say quarter%, but it's you don't want to be too concentrated, but you got to take some electrolytes. There's no question about that.
So, to those people who hear the word electrolytes and wonder what the hell
May-
they are, what's an electrolyte?
Well, we're talking about mainly what we're talking about for this kind of electrolyte is sodium, and that's making sure that you have a bit of salt when you have a little salt water, but there are drinks that you can buy that they're like um, yeah, that's what I would.
So most of them are sodium, magnesium, potassium,
Yeah.
and maybe some minerals in there as well.
But the one I'm most worried about is the sodium. I mean that unless, of course, and most hokum patients are not on diuretics, but if you're on diuretics, that's a real bad problem now. If you you've got to really watch what's going on. If you are taking diuretics because you've had some heart failure symptoms, or you have high blood pressure, and one of the drugs that you're using is a diuretic to treat that blood pressure. Now, most hokum patients are not on diuretics, but if you are, you've got to really be careful.
So, how would one be careful?
You've got to stay out of the heat. If you're really, if it's really hot, and you got to really drink, and you might even eat some potato chips or something like that, just to have a little bit, so you don't get, you don't drop the bottom out of your sodium. But people that need diuretics, that's a different thing, and that in this kind of, nobody's even talked about that on television or anything like that. But that can really be an issue.
So if you are on diuretics and you're in extreme heat, you want to keep fluid going in, you want to make sure that you're peeing, and you want to keep yourself out of the high heat of the day.
That's right.
And if you are not on diuretics, you can do some salt supplements,
right,
electrolyte drinks, your good old Gatorade, Propel, those types of drinks.
Right.
Watch the sugar content,
right,
but get the electrolytes in and keep your volume up as
right,
you get through these hot summer days.
Right.
Definitely. And make sure that you always have a bottle of water with you. It doesn't have to be cold water. It can be cooler water. Some of the thermoses you can kind of keep with you that'll keep the temperature controlled.
Right.
Way better than we used to in the 80s. Those coolers only lasted like 20 minutes. I swear to God.
No, we actually, my wife bought something that I'll get it at the end here. I'll show you. It holds lots of fluid, and it does keep it insulated.
Perfect. That's the best. Okay, so let's say it's not the heat of summer. Let's just move into the nice, cool fall days.
Right.
And we're talking about just generalized exercise with HCM. So I know there's different philosophies and different thoughts on how much exercise is enough, what's too much, but we can all agree that movement and activity for the overwhelming majority of those with HCM is not only good, but beneficial, because you're keeping your body moving, you're keeping yourself fit and healthy, and you shouldn't be afraid to go for a walk. You shouldn't be afraid to get involved with an exercise regimen that's appropriate for your anatomy. And I think everybody's agreed on that for a really long time. Agreed?
Yep.
But sports activity, competitive sports activity, that's where we start to get into who should, who shouldn't, how much, which sports, etc. And what we figured out is we can't make a broad blanket statement, do or don't. It's a shade of gray, and it needs expert evaluation of anatomy, physiology, and the sport that you're doing. Right. Different sports require different levels of energy, and we have to take all of those things into consideration. Would you agree?
Yeah, I think that's true. And I think that if you're really going to do sports, you've got to really get tested, and you've got to have a stress echo so that when what we do a stress echo, we watch your blood pressure response. We watch the echo will tell us what your gradient is. Is it nothing? Is it provocable, or is it gets real, or is it real high? And what happens to your blood pressure when you what happens to your blood pressure when you get a high gradient? You're going to drop your blood pressure. I mean, you got to know all of that if you're going to do some sorts of physical activity. That's mandatory. And if you don't have that, you can't begin to tell somebody what to do. But that's really part of the workup. And the other thing that's very important is we in terms of the anatomy, we need to know what the MRI looks like. Is there how thick is the heart, and how scarred is the heart? If the heart is very scarred, that puts you at increased risk of arrhythmia. And after a certain percentage, more than 15% scarring, then you got to think about a device to shock the heart if you were to have VT. So you got to know all of that before you would, if you were going to go out and do sports. But I'm not too happy about patients with hokum playing football or something like that. That really worries me, and because it's hard to reproduce in a football game what you're doing or it's hard to reproduce with a treadmill what you're doing in a football game. So I think that we got to be. I'm not happy with that at all. Playing football.
I think there are reasons for
Basketball. I mean, there have been basketball players that have just dropped right on the court.
Yes, we've had them, but we also now have an NBA player with HCM who's protected with both primary and secondary because implantable devices and courtside.
Right.
And as we've been evolving over the past 30 years, a couple of things have happened that make it just generally safer than it was 30 years ago. And I've mentioned this many a time. When we look back at the films of Hank Gathers having his cardiac arrest, after he makes a shot, he turns, he stumbles, he gets back up, he stumbles again, he gets back down. The coach comes and grabs him and holds him, literally just holding him as he dies. I don't know how that man has gotten over the emotional trauma of that, but he literally held him. It was 1990. There were no AEDs in gyms. We really weren't thinking of bystander CPR with the same action that we do today. And it took, I think it was like 14, 18 minutes or something like that before EMS arrives and he's already gone. And then you have DeMar. And DeMar's cardiac arrest, January 23, in front of everybody on Monday Night Football. And the emergency response team was to him in seconds, and compressions were started, and the AED was brought out, and he is back playing. He doesn't have HCM. That was commotio cordis. It's a different cause.
That's right.
But the response was completely different.
Yeah, there's no question about that. But I also you always got to think about, is it really worth the risk? And I guess that's what you gotta. You can't predict commotio cordis. Nobody can predict that at all.
Nope.
But if you have, it depends on how bad we see things are, in any individual patient, and that's what you got to look at. If you've got a heart that's 30 millimeters thick and has a real is really scarred, that's a problem.
And I think most individual physicians treating HCM at the highest levels would say that is not a safe patient for participation at a high level of athletic participation. However, if it's not 30, it's 18 or 20, and there's no scar and there's no obstruction, this is a different scenario. And each scenario has to be worked up as an individual case. And understanding of risk is really important because there is no zero risk. You can be low risk, but you can't be no risk in HCM of a cardiac arrest. So we can do our best, and even the best doesn't always succeed.
Oh,
And I know many cases where there's zero risk factors and we've lost somebody young unexpectedly. And those are tragic, horrible situations. We're trying to get smarter and better, but we're not perfect yet. We're learning. We're way better than we were 30 years ago, but we don't know it all yet. Do you agree?
yep.
Okay. So speaking of student athletes and screenings and knowing who's with HCM is safe to play, there's a whole other world out there, and that is the undiagnosed. So I was in your fair state earlier this week. I was down in Columbus, Ohio at the State House, and we were providing testimony over portions of some legislation that is moving through your State House, and it improves student athlete screenings. And we got some great questions from some of your elected officials asking, well, why aren't we doing this for all well child exams? Why don't we just do all this at once? And I said, thank you so much for the amazing question. We'd be much in favor of that. You can add that language in right now, and we can protect all children in Ohio through questions, through their well child examination, as well as that fortifying that with pre-participation screening physicals, asking about family heart health history as well. So we are moving through with legislation. I hope that we might get a hearing again next week. If that hearing goes through, then we could be up for a vote in September. So it's looking really promising that we'll have another state join the ranks of implementing either all or parts of the Healthy Cardiac Monitoring Act. And big shout out to our friends at Cleveland Clinic who came down to the State House. Melinda Tsai and Dr. Aziz from the Pediatric Electrophysiology Department came down and provided testimony in support of the legislation. So props to Cleveland Clinic for coming on out. Props to Judy for being the patient who came and provided some testimony. So thank you all for everybody who showed up at the State House. We'll be doing more of this type of work in the coming months and years. So if you would like to change the rules in your state and improve cardiac surveillance through proper questioning, get in touch with us, and our legislative lead, Julie Russo, would be more than happy to get you engaged in our work. So yay, Ohio. So I'm happy about that one. It's always good to see things moving in the right direction. And you and I have been around this game a little while, Harry.
Yep.
30 years ago, you have HCM, sit on a bench, no more sports, no more activity, because we didn't know how to predict risk. We couldn't protect people with ICDs. There was no AED. CPR in the field was working very poorly. We've gotten better at everything. Hands-only CPR, AEDs, ICDs, proper risk assessment. We've come a long way. I like that. What do you think needs to happen next?
No, I think the most important thing is that people need to be screened in general. I mean, that's yeah. I mean, I think the medical profession has to take more responsibility than it has in lots of things. But I think that we shouldn't be afraid to screen people, and I think that's it's important that when you're in a school or it's interesting, even in airports now you find AEDs, and I think that
everywhere.
Yeah, and I think that's extremely important, and I've had a few episodes on airplanes where I was the only doctor on the plane or something like that, and I've had to do something. I can't remember that I ever had to really give somebody true CPR, but but you gotta be you have to be ready to do something like that. It's interesting that I can remember one time on a plane where they um, a stewardess was there, and she was on a telephone that was plugged into the ceiling of the plane, talking to somebody about what was going on. And that was, it. So she could have her discussion with whoever, whether it was somebody, the pilot, or somebody off the plane, talking about what was going on with this person without, making the whole plane truly aware of what was going on. So people don't get panicked. That's important too. That you control the crowd. That you can manage it without everybody having to know exactly what's going on.
So another interesting thing that's happening legislatively right now, and it ties into exactly what you're saying. There's a piece of federal legislation called the HEARTS Act. Back in 2009, I helped draft the original version. It's evolved quite a bit since then, and it only got better and stronger. But this will provide federal funds to the CDC specifically for cardiac arrest preparedness in high schools, and I think it's K through 12. I don't know exactly where the funding will go. But it's not just AED placement and CPR training, it's emergency preparedness. It's what we call the Drill Dr. Heart program. It's making sure that if you're in a group of people, let's say you're at Temple on Saturday and the AED is there, and I know your Temple has an AED, and something happens, well, what do you do? Who's getting the AED? Who's CPR trained? Who's calling 911? Who's going to the door to make sure EMS goes to the right door of the facility to come in most expeditiously? So having a conversation with your groups. So whether it be your work group, your church group, your sports group, whoever your group of people are, book club people, I don't know, retirement home, and recreation room, whatever. If somebody goes down, what's the plan? Who knows CPR? Who knows how to use an AED? Who is comfortable in doing this? And if they're uncomfortable, well, they're the alternate, but they're going to have to do it anyway. So making sure everybody knows the rules. The closest AED may be in a police car. And if that's where your closest AED is, and that's what you have to do is call 911 to get it there, then you keep doing compressions until that cop shows up.
We have it in our synagogue.
I know, because I think you put it there, or you helped get it there.
I don't know that I've ever shocked anybody there, but I've had episodes where people have gotten into trouble. And
you need to be able to respond to those. We don't know that they're HCM, coronary artery disease, aortic dissections. We don't know what's going on in the moment. We know somebody's having a cardiac emergency, and the best thing we can do is make sure that their heart stays beating, either with CPR, shock it back with an AED, and get them into the emergency room as quickly as possible, because that's where real recovery is going to happen.
Yeah.
And we had a member of the community have his ICD appropriately discharged in a gym a couple of weeks ago. They happened to catch it on video. I'm asking, we might be adding it to his story on our website soon, so you can see a real cardiac arrest. It's a little scary, but he gets up and he's here to tell the tale. Probably going to podcast with him on this one and go over that episode. But we can't save people if we don't diagnose people. If we don't ask the right questions, we're never going to open the door for diagnosis. We're not mandating in any one of our legislative pieces a particular test for anybody, because it's not always the same test that's going to find a disease. If you have an anomalous coronary artery, your EKG could be normal, your echo could be normal, but you're going to need a CT scan to see where that is. So you can't mandate a test because it's not going to find all the diseases. You can mandate the questions to be asked, and we can help educate people on why they're being asked and how they should respond based on their family history, so that they can get the appropriate testing: echo, EKG, MRI, CT scan. There's so many things that could be needed to be done. And we want to make sure people get to diagnosis in time. So we have so many new treatments out today and so many things that we can do with proper guidance and consultation on exercise, that we want to make sure people have the message. So much to do. So much to do. So the other thing that is going on in our world is going to take a slight pivot here, Harry, and show everybody what we've created here. Um, as many of you know, and if you don't, and you're hearing it for the first time, I'm sorry to be the one to tell you. Dr. Aslan Turer of UT Southwestern's HCM program passed away about 3 weeks ago. And it was sad and not completely unexpected. He had been battling a disease for a while, but he was pretty well. And he worked on Thursday and he didn't go in on Friday. He had passed away. So what we had asked was for members of the community to share their memories of Dr. Turer so that we could put together a scrapbook to share with his children so that when their mom feels it's appropriate for them to read this scrapbook, it will be available to them so they can get a different glimpse of their dad. And this is what the book now looks like. It's a nice little scrapbook and it's got nice pictures and stories from patients and pictures that they've taken of him and just little messages of hope and kindness. And we have some letters from his colleagues as well, and some space for additions as we go forward. So we're super happy to be sending this down. His wife should get it next week. And when she feels it appropriate, she can share it with his children, their children, and hopefully they'll have some loving memories of their dad. So not my favorite project to ever work on, but I thought it was really nice of the community to come together and share their thoughts about Aslan with everybody. So we've got that. What else do we have coming up? New clinical trials in HCM. More myosin inhibitor trials coming. More other trials coming. Harry, where do you think we are today compared to where we were 20 years ago with options for HCM management?
Well, I think it's much better now, and I think the new drugs look like they're going to be a big help, and I think it's important, and I think that I just feel bad that over the years we never did enough studies with the older drugs, because it would have been some help, with the beta blockers, the calcium channel blockers, and when you go back and you look at what was done, nothing compared to what it is now, and but I think part of the problem was we weren't organized enough with centers of excellence to be able to do those kind of studies. I don't think it was, people, the average physician didn't understand a lot about hypertrophic cardiomyopathy. So, and certainly what you have put into this thing, this disease is incredible, and things wouldn't have gotten as far as they have now without the Hypertrophic Cardiomyopathy Association and everybody, working together. I mean, that's what's really important.
I couldn't agree more. And the secret is about 20 some odd years ago, the concept of more centers had a lot of reasons for it. Not everybody can get on a plane and fly to Cleveland or go to Boston or go to Minneapolis at the time. People just couldn't travel. So especially with the onset of ACA in about 2008-9, we thought it was really important to try to get a center in each state. And as of last week, we have approved our 51st program. So this is an announcement. It's not the formal announcement. It's the podcast announcement. But the team at Johns Hopkins is back in the Center of Excellence fold with Dr. Jose Madraza as the director. And we're super excited to have him back on the team at Hopkins. And I will be heading out to Seattle to look at 2 programs this summer. And we'll be doing a meet and greet in Seattle. So Seattle peeps, look for it. We'll be out there the end of July in about a month. So we're looking forward to seeing you. And 2 very interesting programs in Seattle are being reviewed. So these hubs of patients allow us to have a bigger infrastructure for clinical trials. So when they started looking around in 2014-15 for can we do trials in HCM, all of the sites were HCMA recognized centers of excellence. They were all our programs. And that's where all the trials actually percolated. And we were able to populate these trials in a timely fashion, making them efficient and getting drugs to patients pretty damn quickly. If you go that myosin inhibitors were a concept in 2013, and we got a labeled indication for HCM by 2022, that's a really impressive timeline for a completely new category of agent. It's not another beta blocker. It's not a sodium channel blocker. It's not a calcium channel blocker. It's a completely new mechanism of action. And to get it from concept to patient in under a decade or just about a decade, pretty damn good. And we got to do that again. And we got to get better drugs and we've got to get better treatments. Now we even have gene therapy coming up the line next. What do you think about gene therapy, Harry?
Well, I don't know. I think it's new, and we just are going to have to see what happens. I'll tell you one thing that's worrying me in general. It's hard for patients to get appointments in lots of places now. There's a shortage of physicians, and we've got to. This COVID has done some bad things in terms. Let's forget the disease for a minute, but in terms of, it's caused shortages of physicians because they get tired and a lot of them have quit. And so you don't have as many physicians as we used to have. So that's got to be looked at very carefully. And that's I always hear from people that I can't get an appointment. And that's another thing that's going to have to be, it's got to be fixed.
I don't quite know how we're going to fix that one. There's so many push and pulls going on here. Insurance companies don't want to actually pay for things. They want you to jump through hoops and they make it so difficult. And then you have the shortage of administrative staff, nursing staff, physician staff. There's a lot of very long waits throughout the United States right now for physician appointments. And, I had a situation occur this week or last Saturday, actually, where somebody came into the community on the private Facebook group with a very striking echocardiogram, like very striking, septal measurement north of 4.5 and young, very young and symptomatic. And they were offered an appointment in October. Mm-hmm. They're being seen today. We got involved. And I'm like, nope. No, we're not waiting till October on a young one with that kind of a measurement. So thankfully, HCMA has back doors into every center. And if there's something that is urgently needed, we can respond. Obviously, not everybody can jump to the front of the line all the time, and you do have to wait for your appointments. So we do encourage people to set their appointments well in advance, that they keep an annual appointment so they don't let things get ahead and maybe symptoms start to steamroll and you need an urgent appointment, and it's very hard to get an urgent appointment. So schedule your yearlies, go in and talk about your symptoms, be very factual about what's going on. Keep your logs. We have the patient journey journals so that you can keep track of your symptoms, how often they've been happening. You can use your Fitbit or Apple Watch data to help track how well you're doing and share that information with your doc when you see them once a year. This is my monthly average of steps. This is my average of sleep. This is what I'm doing. Here's all of my health metrics. These little jobs on your wrist hold a lot of data. And if you start tracking yourself and you see yourself walking less, sleeping less, or sleeping more and doing less, these are conversation starters for your doc. What am I doing? How can I do better? How do I optimize my health? Maybe your goal is some weight loss. Maybe your goal is to walk 1,000 more steps a day on average. Maybe your goal is to bring your A1C down. Know what your numbers are. Take care of yourself and make preventative appointments well in advance so that you're not in a situation where it becomes really urgent. We have a chronic illness in HCM. Stay on top of it. Right. What else would you suggest?
Well, I mean, I think that, I don't want to, I don't know. There are other things we can talk about, but I don't want to get too political here. But there are other issues that have to be concerned with, and I don't want to get into it now. But
So I will open this door a little bit. We have a presidential debate next week. We have a major election in this country. I'm not going to piss off either side by saying this or that, but I will say this much. We need to evaluate who has a health care plan, who does not have a health care plan, and what that health care plan is, and what the relationship between doctor and patient are going to be going forward. Are we going to have government oversight of the doctor's office? And if we're going to have government oversight of the doctor's office, is it on everybody or is it only on one gender? And I think the answer is government does not belong in the doctor's office.
no.
End of story.
Well, if you want to talk about that, I can really talk about it. I mean, one of the problem is that the doctors have got to be afraid not to practice medicine. And I've known of cases of patients with hokum who became pregnant and desperately needed an abortion to save their life. One case in particular that I dealt with many years ago would not have survived if we had not done the abortion. And you can't be afraid to tell people what you think and what needs to be done. And that, doctors have got to, if we're the ones with the knowledge, and it's not a political decision, that's the problem. And you can't be afraid, to have to send somebody thousands of miles to get taken care of is totally inexcusable. And I'm, that's a problem. And, you got to know what's right and you got to do it.
We need to make sure that pre-implantation genetic diagnostics remains available. And for those who don't know what PGD is, you need to do IVF.
Yep.
So you create an embryo or multiple embryos. You genetically test those embryos. If the embryos are HCM positive, you do not implant them. Right. And you implant those who don't have the genetic mutation. In fact, anybody out there who's done PGD, you're going to be hearing from me soon, because I was just in New York City yesterday and I was talking to Mark Sherrod, who's doing a review of PGD and HCM. So we're going to need to talk to all of you who've done it. And we've been able to create HCM-free children within HCM families. And that is a miracle in and of itself,
right?
That we're able to stop suffering and stop disease in these families. So you have the PGD pathway, which requires IVF. And now we have this slippery slope that typically embryos that weren't implanted were destroyed. And that was done with the consent and knowledge of the parents.
Right.
And now they seem to not want to do that in some states. And I don't quite understand what the end game here is. We've spent billions upon billions of dollars to understand the human genome and use it for the betterment of society and health. And that's what we can do with PGD. And it's beautiful when you can stop a disease that has tormented families, taken family members too young. And for people who have lived with these diseases, the opportunity to have a child free of these burdens is just absolutely amazing. I wish it was available for me back in the 90s, but it just wasn't there yet. So I think it's really important that we talk about the anonymity and the ability of patients to make decisions that are right for them and their families without government oversight or overreach.
That's right.
Amen. So we need to really focus on who we want to be as a healthcare society in the future and what we're all willing to do to create this reality. We need a plan. What's happening now isn't working. Nobody's pretending that it's all good. Nobody will tell you it's good. Hospital CEOs, payers, politicians, patients, families, statistics. one major healthcare plan, one CEO, it takes over 2,400 families to pay premiums for an entire year to compensate that one individual for 1 year's work. Not one claim got paid. Nobody's health was improved necessarily, but a CEO has a $25 million, pay contract. And that takes 2,400 families paying an average premium for an average plan to pay for that. And that's only one staff member. What about the rest of the C-level office? What about the administrative oversight? How much does it cost to have somebody answer the phone and say, no, you have to submit an appeal. No, you have to submit an appeal. And then have some of those people come in for their appeals and the rest just get intimidated by the system and back off. So we need to focus on where the money's going in our healthcare system and stop this just absolute disgusting greed that's happening in healthcare.
Yep.
I might have some opinions on this topic, Harry, and you and I can talk for more hours and
right.
would be willing to listen to on this, but you have to vote for your health. Yep. And you have to understand the healthcare policies of whatever elected official you're voting for, a congressman, a senator, president. You need to know where they stand on healthcare and whether or not they're willing to stand up for patients or the big payers. Big payers have more money than patients.
Yep.
So we got some issues to deal with there. Other things coming up in June or July. I'm sorry, I'm already in June, but it's July, or it's going to be July. I will be in San Diego. Look for a meet and greet in San Diego as well. I will be down there for a heart failure conference, and we're going to put together a small HCMA meet and greet and maybe a small session on education and advocacy in the San Diego area. So stay tuned for the listing on that and the listing on Seattle. Harry, anything else you want to talk about on this lovely June day?
No, I think we've covered a lot.
We always do, and we always appreciate having you in Tales from the Heart. And we will be back in another week or so with another edition. If you haven't already done so, we really encourage you to visit our YouTube channel, our Facebook group, as well as our Facebook page. Unfortunately, Meta has changed some of the algorithms and the permissions, so we're not able to live stream in the private group any longer, but we are mirroring it from the page. So if you're in the group and you're listening and you had a question and you didn't quite get it through, I apologize. We're trying to figure out some mechanisms around that. But yell at Facebook and Meta because they're the ones who changed the rules. And we're sorry about that. Big shout out to our sponsors for their support. Really proud to announce that HCMA has a new sponsor in Viz AI, which is a technology company that's looking to do cloud reads of EKGs from basically any hospital, like those. If you have their system in your hospital, if you have an EKG, the EKG goes to the cloud. It gets read for signals that could be hypertrophic cardiomyopathy. A specific physician within the program gets notification that you are there, and hopefully we're going to aid the time to diagnosis for some of these patients because we're getting some help from AI technology. So happy to be partnering with Viz AI and seeing what we can do to improve diagnosis of HCM going forward. What else do I have to thank this week? The Ohio State House, big props out for what you're doing for us. We're really looking forward to moving this legislation forward. And I have to say hello to Joey's dog, Carl. Carl and I have a special relationship, and Joey knows what I mean. I just love Carl. He's a great dog. Isn't that a great name for a dog, Carl? He is Carl the dog. I will have to have some pictures of Carl the dog because he's adorable. So on that note, I wish you all a happy weekend. Stay hydrated, stay in the air conditioning. Don't push yourself in the heat. Take it easy. It's okay. You don't have to work at 1,000% all the time. It's a good mellow couch weekend or a lake weekend in the shade. So go take it easy. Have a great weekend, and we'll see you next time on Tales from the Heart.
Lisa?
Whoop, hold on.